Hi, my name is Anna Kileen, and I am a student nurse at the University of Michigan. Today I will be presenting a patient. Patient is an 18-year-old Caucasian female who is single and currently and usually is a student. Her usual source of medical care is a primary care physician through the University of Michigan Health System. Patient's vital signs are a blood pressure of 118/71, a heart rate of 55, a respiratory rate of 14, a temperature of 98.4 taken orally, and an oxygen saturation rate of 98% on room air. The patient's height is 5 feet and 5 inches, and her weight is 145 pounds. Patient is seeking care for chest pain relating to an arterial septal deficit repair in July of 2013, as evidenced by acute pain in the thoracic region during strenuous exercise, accompanied by shortness of breath and swelling in the peripheries. Patient was first diagnosed at 16 years of age, and most recent onset became present 2 days ago during intense exercise. Patient described the pain as sharp, stabbing, intense pain that subsides after a few minutes. Pain is located near the apex of the heart. Aggravating factors include high stress and intense physical activity, and pain is relieved by rest. The patient has treated the pain by discontinuing exercise and taking extra strength Tylenol, 150 milligrams, every 6 hours for the last 2 days. Now I am going to speak about the patient's general health history. Patient's history of childhood illness includes symptoms of undetected heart deficit, including shortness of breath, fatigue, cyanosis, and chest pain, and occasional mild cold and flu symptoms. Psychologically, the patient reports no presence of disorders. Patient is up to date on all immunizations, including a recent flu shot. Her last tetanus shot was in 2012. Patient has no known drug or food allergies or reactions. In regards to hospitalizations and surgeries, patient underwent open heart surgery to repair an arterial septal deficit in July 2013 and a rhinoplasty to correct a deviated septum in 2015. Patient is currently taking 150 milligrams of Wellbutrin and 10 milligrams of Prozac daily. Patient has no history of drug or alcohol use. Patient exercises 2 to 3 times a week through recreational sports and leisurely jogging. Patient sleeps an average of 8 hours a night uninterrupted. Patient ingests around a 2,000 calorie diet through 3 meals and 1 snack a day and follows a vegetarian diet consisting of adequate protein intake. No reported history of caffeine or smoking use. Patient wears a seatbelt, reports no texting while driving, wears a helmet and sunscreen. Patient's parents have been married for 30 years and is the youngest of 4 children. She has 3 brothers with the ages of 25, 28, and 22. No reported issues within her family or friend relationships. Patient reports daily stress levels as 6 out of 10 daily. Stressors include attending school at the University of Michigan and managing time in her daily activities. Patient lives in a school-funded dormitory and is very seldomly exposed to secondhand smoke. Patient is a practicing Anglican and is highly involved in her church community. Patient has a high school diploma and is currently enrolled in a bachelor's program at a university. Patient receives a yearly physical through her primary care provider and also sees the dentist twice a year for a dental exam. Patient's immediate and extended family has no history of heart deficits. Patient's mother presents a history of depression. Patient's oldest brother suffers from bipolar disorder and schizoaffective disorder. Patient's middle brother suffers from PTSD, and patient's younger brother suffers from depression. Her maternal grandfather died of a heart attack at age 73, and maternal grandmother passed away from colon cancer at age 72. Patient's paternal grandfather died of renal failure at age 83. Patient's paternal grandmother died of lung cancer at age 74. Patient's extended cousin died of Crohn's disease. While reviewing the patient's cardiovascular system, patient indicated chest pain near the apex of the heart that occasionally radiated down the left arm during strenuous exercise. There is a murmur present. No history of HTN. Fatigue present chronically, and patient reports not feeling well well rested upon waking. Patient has no reported problems walking. Patient also has no difficulty lying flat, and few pillows are needed for comfort during her rest. Patient experiences palpitations during exercise. While reviewing the patient's periphery system, no pain was reported in upper and lower extremities while walking or lifting. Edema is present in phalanges during exercise. No report of hair loss. Patient reports often being chilled and also reports poor circulation as evidenced by cyanosis. No history of varicose veins or blood clots in legs. Capillary refill is within 2 seconds. Patient has lower pulse due to being a well-trained athlete. During the physical examination of the cardiac system, there were no heaves or lifts upon inspection of the 5 key areas of the chest. The chest is symmetric with no observation of injury, bruising, or deformity. Absence of lifts or thrills in 5 key areas upon palpation. The point of maximal impulse graded as a 2+ at the apex of the heart. Auscultation over 5 key areas with the bell and diaphragm occurred while the patient was in sitting position. S1 and S2 sounds were auscultated. There was a slight murmur heard before S1, constituting an abnormal finding, but no other S3 or S4 sounds were heard in auscultation. Next, the patient was put in a supine position, and S1 and S2 sounds were auscultated in all 5 key areas using the bell and the diaphragm of a stethoscope. Upon rolling on the left side, abnormal S3 and S4 sounds were confirmed absent. Apical pulse was 55 beats per minute, achieved through auscultation of the mitral area. Next, the patient's peripheral vascular system was assessed. Lower extremities showed no signs of abnormal hair distribution, ulcers, or varicosities. During the exam, no edema was found upon palpation. Palpation of the arteries showed no abnormal symmetry, rate, rhythm, or amplitude. Next, the carotid arteries were palpated one at a time to prevent restricted blood flow to the brain. Popliteal and dorsalis pedis were both found and graded as a 2+. Each pulse received a grade of 2+. No presence of varicosities, tenderness, edema, or warmth. Skin was cold to touch. Capillary refill was found to be under 2 seconds, which was a normal finding. The pertinent systems related to this patient are respiratory and abdominal. According to research done by Paul Taylor, MD, acute stress ulcerations of the stomach and duodenum is being reported with increased frequency after surgical procedures of the major arteries and the heart. Based on the patient's recent history of cardiac surgery, the abdomen would be important to assess. In this assessment, the abdomen would be examined for any palpable pain that could lead to findings of ulcers as a result of the cardiac surgery. Excuse me. Furthermore, according to research done by Charles Weissman, MD, respiratory complications remain a leading cause of post-cardiac surgical morbidity and can prolong hospital stays. Because of the patient's recent history of cardiac surgery, a nurse would assess the respiratory system to make sure no complications were arising in the lungs. This concludes my presentation of my patient's information. Thank you.